Most people spend $200 on a tactical medical kit. It holds $40 of actual gear. The centerpiece is often a counterfeit tourniquet. Meanwhile, the item that saves the most lives sits on a Walgreens shelf. It costs less than a bag of chips. I'm going to walk you through what a Special Forces medic actually buys there. 12 items, every one traceable to combat medicine or published trial data. You leave with a shopping list, not a fantasy, and you learn why the pharmacy aisle beats the internet on medical resilience. Let's go. This is the first thing. Not a tourniquet, not a chest seal, not a $200 tactical bag. The first item a Special Forces medic drops in the cart at Walgreens is a paper sachet of oral rehydration salts. It costs less than a bag of chips, and it does more real work in a disaster than anything else you can legally buy on a shelf. Here is why. In a non-permissive environment, the pattern of who dies is well documented. Think a hurricane zone or a grid-down region. Dehydration from acute gastroenteritis kills first. Wound and skin infection kills second. Chronic conditions like diabetes and hypertension decompensate third. Traumatic injury sits fourth. Fluid loss is the actual killer, not bullets. The mechanism is worth understanding. Your small intestinal lining carries a pathway called sodium-glucose cotransport. It hauls one molecule of glucose and two sodium ions across the cell together. Water follows osmotically. This pathway keeps working even when your gut is inflamed and pouring out secretions. That is the biological reason oral rehydration therapy saves lives when a patient looks like they need an intravenous line. Without glucose in the right ratio, sodium uptake in a compromised gut stalls. Plain salt water fails you. Sugary sports drinks fail you differently. The sugar-to-sodium ratio is wrong. The formula matters. The World Health Organization published the current reduced osmolarity formula in 2003, jointly with UNICEF. Per 1 liter of clean water, mix 4 ingredients: 2.6 grams of sodium chloride, 1.5 grams of potassium chloride, 2.9 grams of trisodium citrate dihydrate, and 13.5 grams of glucose. Total osmolarity comes in at 245 milliosmoles per liter. Trioral and Ceralite are two pharmacy brands that carry the ratio. You pay in the low single dollars per sachet. The World Health Organization credits this therapy with saving tens of millions of lives since the 1970s. They call it one of the most significant medical advances of the 20th century. It sits on a Walgreens shelf. Most people walk past it because it doesn't look tactical. Most people assume sports drinks cover this problem. Reality is different. Sugary sports drinks with the wrong sodium ratio fail differently. That's the source doc's point. A sports drink is a sweat replacement product. It is not the correct tool for cholera-adjacent gastroenteritis, norovirus, or traveler's-type diarrhea. That mismatch is what kills you when clinical care is hours or days away. If sachets aren't available, use the field backup. 6 level teaspoons of table sugar, 1/2 level teaspoon of table salt. Dissolve in 1 liter of clean water. That approximates the ratio. It is not exact. The pre-mixed sachet is preferred because the ratio is repeatable and the packaging survives storage. Bloody stool, high fever, or altered mental status still need professional care. This is not medical advice. I've put together an offline pharmacy shelf guide for you with the 245 millismole formula in the description's first line. Pain and fever, 3 drugs. An 18 Delta doesn't stock 3 bottles of the same painkiller. You stock 1 bottle each of 3 drugs because each does a job the others can't do safely. Acetaminophen, ibuprofen, aspirin, different tools, different jobs. Acetaminophen at 500 milligrams per tablet is your fever and pain workhorse. It spares the stomach lining. It spares the platelets. It plays nicely with almost every patient in your household. Its danger is the liver. Overdose is hepatotoxic. Current adult labeling Caps the daily dose in the range of 3 to 4 grams. Stack multiple cold and flu products that contain it, and you'll blow past that ceiling without knowing. Ibuprofen at 200 milligrams per tablet, sold over the counter, is your anti-inflammatory choice. It is the right drug for musculoskeletal injury, sprains, dental pain, and menstrual pain. It works by shutting down inflammatory prostaglandins. That mechanism has a cost. Ibuprofen is nephrotoxic in the dehydrated patient. It increases bleeding time. So it is the wrong drug for the dysentery patient. It is the wrong drug for the trauma patient with active bleeding. Civilians reach for Advil in the dehydrated patient. That's exactly the wrong drug. Aspirin at 325 milligrams earns a slot for one reason nothing else can fill. In suspected acute heart attack, a chewed dose of 162 to 325 milligrams is a documented intervention. That is why aspirin sits on your shelf even if you never treat a headache with it. You want it there for suspected acute myocardial infarction in an adult. Most households own one giant bottle of one drug, usually ibuprofen, because it worked for a headache once. The trained approach is a bottle of each, stored cool and dry. Solid oral dosage forms under the Department of Defense Stability Program have routinely retained potency for years past their printed date. Your bathroom cabinet isn't a climate-controlled warehouse, so treat that data with respect. Don't treat it as licensed to hoard pills for a decade past expiration. Each of the three costs a few dollars per bottle at Walgreens. They cover fever, pain, inflammation, and the single biggest household cardiac intervention you can perform while waiting for help. Contraindications matter. Ibuprofen and aspirin have specific problems in pregnancy, active ulcer disease, and certain bleeding conditions. If you don't know the drug, ask the pharmacist standing 10 feet away. This is not medical advice. Diarrhea has a stop button. Loperamide, sold as Imodium and store brand equivalents at 2 milligrams per tablet, is a peripherally acting mu opioid receptor agonist. It slows intestinal motility. At normal doses, it does not cross the blood-brain barrier, so it does not sedate or produce euphoria. That is the reason you can buy it off a Walgreens shelf next to the antacids. The standard over-the-counter dose is 4 milligrams to start, then 2 milligrams after each loose stool. Cap yourself at 8 milligrams per day for self-treatment. A 24-count box sits in the low single dollars at Walgreens. You want it in your kit alongside the oral rehydration salts. The two work together. Here is the clinical rule in 18. Delta learns cold. Loperamide is a tool for watery, non-inflammatory diarrhea. It is contraindicated in 3 situations: high fever, bloody stool, suspected invasive bacterial infection, or Clostridioides difficile colitis. In those cases, slowing motility traps the pathogen in your gut. The infection gets worse. That is the mistake civilians make when they reach for Imodium during dysentery. The drug helps the wrong kind of diarrhea and hurts the right kind. Civilian approach versus trained approach. The civilian sees loose stool, pops 2 Imodium, and moves on with their day. The trained approach asks 3 questions first. Is there blood? Is there a high fever? Is the patient looking systemically sick? If the answer to any of those is yes, you don't stop the motility. You push fluids, you stabilize, and you get the patient to a clinician. In 2016, the Food and Drug Administration issued a formal drug safety communication about loperamide. High doses, largely in the setting of abuse for opioid effects, are associated with serious cardiac events. Specifically, prolongation of the QT interval, torsades de pointe, and cardiac arrest. The other thing loperamide is not is a rehydration drug. It slows down the plumbing. It doesn't replace what has already been lost. So you pair it with the oral rehydration sachet from item 1. Loperamide buys you time. Oral rehydration keeps the patient alive during that time. Use them together, or you get half the value of each. The multifunction pattern is straightforward. Traveler's diarrhea, norovirus in a family group, long car evacuation with a sick child, grid-down setting with limited toilet access. All of these are the correct use case. Bloody stool with fever needs evaluation, not an anti-motility drug. This is not medical advice. You need 2 antihistamines, the 18-delta stocks 2, because they solve different problems on different timelines. The first is diphenhydramine, sold as Benadryl or store brand at 25 milligrams per tablet. It is a first-generation histamine receptor blocker. It crosses the blood-brain barrier freely, which means it sedates. That sedation cuts both ways. It is a feature when a patient needs to sleep through an itch, a mild allergic reaction, or a rough night. It is a hazard when the patient needs to drive, make decisions, or stay alert during a family emergency. It is particularly dangerous in elderly patients and in any combination with alcohol or opioids, so you dose deliberately, not by habit. The second antihistamine is loratadine, sold as Claritin at 10 milligrams per tablet, or cetirizine, sold as Zyrtec at 10 milligrams per tablet. Both are second-generation blockers. Both have minimal central nervous system penetration. Both give you daytime allergy control without the mental fog. Store-brand versions of either run well under $10 for a bottle of 100 tablets. Most households stock one antihistamine, usually Benadryl, and assume it handles everything. The trained approach stocks both classes. You reach for the sedating one at night and the non-sedating one during the day. You never sedate a patient who needs to be able to describe a worsening symptom. Now, a critical clarification, because civilians get this wrong at the cost of lives. Neither antihistamine treats anaphylaxis. Anaphylaxis is airway swelling and cardiovascular collapse. The treatment is intramuscular epinephrine delivered by autoinjector, which is prescription only in the United States. Antihistamines are an adjunct after epinephrine. They are not the first move. If you own an EpiPen for someone in your household, you also own the antihistamines as backup, in that order. The multi-function pattern for the pair looks like this: seasonal allergies during a long shelter in place, insect sting, itch and swelling. Contact dermatitis from unfamiliar plants during evacuation. A child with poison ivy on a hiking trip. Sleep disruption during a stressful night, using diphenhydramine as an occasional aid, not a nightly crutch. The dosing schedule matters less than the class awareness. Read the package. Watch for combination products that already contain an antihistamine. Do not stack a nighttime cold remedy on top of a Benadryl on top of a sleeping aid. The sedation compounds. The anticholinergic load spikes. That is how you end up with a confused elderly patient. Store both classes cool and dry. Rotate them. The source doc is clear on this. Shelf life extension program findings apply to controlled government storage, not to a bathroom cabinet. New stock is cheap. This is not medical advice, particularly for anaphylaxis, which is an epinephrine problem first, always. Here is the wound care baseline nobody wants to sell you. The pharmacy aisle sells the exact same rolled and folded gauze that fills a military aid bag, because it is the same gauze. No retail markup for a nylon pouch with a snake logo on it. This is where the tactical retailer economy stops making sense. Start with Kerlix-style rolled gauze in 4.5-inch width. It is the workhorse for wound packing, dressing coverage, and joint wrapping, a few dollars per roll. Keep several rolls on hand. You will burn through more than you expect during any real event. Next, 4x4-inch sterile gauze pads. These are your direct pressure layer and your dressing base. They come two ways: individually wrapped sterile packs for open wounds, bulk non-sterile bricks for cleaning, padding, and non-wound uses. Both have a place in your kit. Do not use bulk non-sterile pads on an open wound. Do not waste sterile packs on cleaning a scrape that is already contaminated with dirt. Medical tape comes in 3 flavors worth stocking. Paper tape for fragile or elderly skin, because it releases without tearing off the top layer of skin. Cloth tape for durable general use where you need adhesion under movement. Waterproof or transport style tape for anything that will get wet or has to hold under exertion. Keep one of each type in the kit. Add a 3-inch or 4-inch elastic bandage in the ACE style. It provides compression for sprains and secures bulky dressings without cutting off circulation, provided you wrap it correctly. One more item that most household kits miss: a petrolatum impregnated gauze such as Zeroform. It is worth adding for burn care and for improvised chest seal use when nothing better is available. It costs a few dollars for a stack of individually packaged squares. The whole baseline can be assembled at Walgreens for well under $40. It is functionally identical to what the tactical retailer resells for a much bigger price tag with a marked-up label. This is the moment you notice the same item sitting on both shelves and you buy the cheap one. Most people buy a pre-packaged first aid kit with adhesive bandages and antiseptic wipes and think they are covered. The trained approach ignores the pre-packaged kit and buys the individual components loose. That way you actually have volume, you control the sterility, and you can restock component by component after use. The multifunction value is high. Every one of these items serves several roles: direct pressure, dressing anchor, joint support, burn coverage, improvised airway padding. That is why they earn permanent shelf space, and that is why you don't need the internet's version of any of them. 2 bottles, 2 different jobs. The 2 antiseptics that belong on your shelf are povidone iodine at 10%, sold as betadine, and chlorhexidine gluconate at 4% scrub, sold as Hibiclins. They look similar. They do genuinely different things. Buying one and skipping the other leaves a hole in your capability. Povidone iodine is a broad-spectrum iodophore. It kills a wide range of bacteria, viruses, and fungi on contact. It is the field medic default for wound edge preparation and for dilute wound irrigation. You do not pour it straight into a wound bed at full concentration. You dilute it, typically to a weak tea color, and you use it as an irrigation additive when clean saline or clean water alone is not enough. Chlorhexidine gluconate does something povidone iodine cannot. It has a property called substantivity, which means it binds to skin proteins and continues antimicrobial action for hours after you apply it. That is the reason chlorhexidine is the standard preoperative skin scrub in most operating rooms in the United States. Your surgeon paints your skin with it before an incision. The antimicrobial effect keeps working while the cut is being made. The evidence base is worth flagging. Meta-analytic evidence, including the Darwish 2010 New England Journal of Medicine trial, shows chlorhexidine alcohol reduces surgical site infection compared to povidone iodine for skin antisepsis in many contexts. Povidone iodine still has advantages. It is safer around mucous membranes. It is what you use for open wound irrigation and dilution. Chlorhexidine is generally avoided in those contexts, so the household pattern is straightforward. Chlorhexidine to prep intact skin before a procedure or a surgical-style hand scrub. Dilute povidone iodine to clean around a wound. Chlorhexidine and povidone iodine each earn their spot for specific and different jobs. Both bottles are under $10 at Walgreens. You want a small bottle of each on a shelf that stays cool and dry. Do not pour either into the eyes. Chlorhexidine has specific contraindications, particularly exposure to the middle ear during ear irrigation. For the eyes, you want sterile eye wash from the same aisle, which is exactly what item 9 covers. This is antiseptic use, not treatment. This is not medical advice. 3 tubes cover most of what walks into a rural clinic. The first is triple antibiotic ointment containing bacitracin, neomycin, and polymyxin B. It is the pharmacy standard for minor abrasions and superficial wounds. Total cost of all 3 tubes is under $15 at Walgreens. Some patients develop a well-documented contact dermatitis from the neomycin component. Those patients switch to plain bacitracin ointment, which is sold on the same shelf. If your household has a member who reacts to triple antibiotic, keep the plain bacitracin tube